be moderated by Dr. Nicholas Hadi, and the second panel session will be moderated by Catherine Thomas. Our speakers for the first panel of today will be Dr. Yuda Turana, neurologist of School of Medicine and Health Sciences of Atma Jaya Catholic University of Indonesia. And the second one is Dr. Riwanti Estiasari from Department of Neurology of University of Indonesia. And the third speaker of the first panel session will be Dr. Patricia Price, PhD from Curtin Medical School of Curtin University. And the second panel session in this afternoon of Jakarta time, we are pleased to have another 3 great speakers. The first one will be Dr. Yandri Supranto from Department of Internal Medicine, Gadjah Mada University. The second speaker will be Dr. Rewari from WHO Southeast Asia Regional Office, and the third one will be Ms. Leni Sugiharto of the Yayasan Sri Kandi Sehati. This event will start at exactly 9:30 local Jakarta time, and throughout this event, should you have any queries, it can be delivered through the Q&A box provided below, and answers will be given during the discussion sessions facilitated by the moderators. As participants and attendees, you are also welcome to use the chat features to greet or to initiate discussions among the participants. Please be advised that the entire event will be recorded and broadcasted live through YouTube. During the symposium, we will also provide interpretation features, and you can find it in the bar below, and look for a globe icon. If you wish to listen for the English version, you may click English or click Japanese for Indonesian. So in general, today's event will be divided into 3 sections: third panel session, poster session, and fourth panel session. If you wish to view the first and second panel session of yesterday, you may find it in YouTube and search for Pusat Penelitian HIV/AIDS Unika Atma Jaya. And now, without further ado, let me introduce Ibu Kritayawan Buntu, or we fondly known as Ibu Tina, as the Country Director of UNAIDS Indonesia, to give a keynote speech of the day. Ibu Tina, the floor is yours.
Hi, hello everyone. Good morning. I hope everyone is keeping very safe. We are still not over this COVID situation, so wish everyone is staying very safe. So I'd like really to thank the organizers for inviting me to speak today at this first international symposium on HIV and aging. It's a subject matter that is becoming increasingly important. I will get right to it. As people living with HIV age, they face more health challenges, as all aging people do. However, there are things that people living with HIV are more affected by. We're still on the first slide, sorry. Are affected by, and both community and healthcare workers really need to be aware of. This is especially relevant as the number of people living with HIV over 49 years old is rising globally in Asia Pacific and also in Indonesia. So this morning, I'll be providing an overview of the data and trends. I'll also be talking about the impact of HIV at older age and highlight some of the NCDs that older people living with HIV are prone to, and provide some recommendations for policymakers. Next slide, please. So on data and trends globally, as we see that the HIV response is accelerated globally, we reach closer to achieving our 95 targets. More people are knowing their status, more people are on treatment, and more people are virally suppressed. Now, due to this, thankfully, the number of AIDS-related deaths has been decreasing, and this trend can be seen at country, regional, and global levels. Looking at the slide, looking at the graphs, the AIDS-related death among people living with HIV older than 49 years old increased from 30 years ago of 37,000 people died of AIDS-related deaths, and it peaked between 2004 and 2006 at 270,000 deaths. That's 10 years later than 1990. And last year, that number reduced quite drastically, almost 50%, to 140 deaths, 140,000 deaths last year. So we can see people living with HIV surviving longer. The number of older people living with HIV increased from 640,000 people in 1990 to more than now 8 million people in 2020. This represents 1 in 5 of the global people living with HIV population. Next slide, please. Looking at the data for our region, we also see a similar trend where older people living with HIV went from less than 2,000 deaths in 1990 to a peak of 70,000 deaths in 2007, and followed by a decline to 31,000 in 2020. So this is really good news. And we see an increase in the number of people living with HIV over 49 years old from 59,000 people in 1990 to now 1.4 million people in 2020. And in Asia Pacific, older people living with HIV now make up 1 in 4, account for 1 in 4 of the total Asia Pacific people living with HIV population. Next slide, please. In Indonesia, as people living with HIV also live longer, we see the same trend. We had less than 100 people living with HIV who were over 49 years old in 1990. And last year, we are seeing 13,000 people living with HIV over 49 years. This also doubled in the last 5 years. So projecting this national data further, we can expect by 2025 up to 27,000 older people living with HIV. And by 2030, we can expect up to 55,000 older people living with HIV. So this increases from 2% of the entire PLHIV population in Indonesia now to 5% in 2025 and 11% by 2030. Slide, please. So in Asia and the Pacific region, unfortunately, there are really only very few studies. And these studies from China, India, and Thailand are showing trends and projections that are consistent with global literature. We see the number of older people living with HIV increasing significantly. And we also see that newly diagnosed HIV among older people living with HIV is also increasing. We also expect to see more non-AIDS morbidities and increased treatment complexity among older people living with HIV due to them being on ART for a long period of time and drug interactions from treatment of comorbidities. The studies also stress an increased need for research on HIV and aging to inform and prepare physicians and health systems. Slide, please. HIV infection at older age. Older people living with HIV who are not on treatment appear to progress more rapidly to AIDS than younger people who are not on treatment. Several studies have shown that after starting ART, CD4 reconstitution is significantly slower among older people. So early initiation of treatment is therefore extra important for newly diagnosed older people. Evidence also shows that older people are less likely to be routinely screened for HIV and are more likely to be diagnosed late in the course of HIV infection. Slide, please. Aging with HIV. As HIV has now transformed to become a chronic manageable condition, the increased lifespan of people living with HIV and reduction of the development of AIDS and AIDS-related deaths is a real achievement. However, we are still learning about the effect of HIV on health and older age. People living with HIV who are aging can have earlier onset of other chronic diseases. For example, people living with HIV have long been known to be at increased risk of certain AIDS-defining cancers, such as Kaposi sarcoma, cervical cancer, and anal and non-Hodgkin's lymphoma. People living with HIV tend to develop such cancers younger and have advanced stage cancers more frequently, so HIV leads to early or accelerated aging. Slide, please. Non-communicable diseases. As people living with HIV get older, they are also more prone to non-communicable diseases. A 2015 modeling studies from the Netherlands, which already has a larger aging population than Southeast Asia, predicted that in 2030, 84% of people living with HIV will have at least one NCD, compared to only 29% in 2010, and 28% of the people living with HIV would have 3 or more NCDs. This will be driven by cardiovascular disease and long-term use of medicines. Comorbidities often need to be treated by different medications, but because of contraindications and drug interactions, the study also predicts that by 2030, 40% of patients could have complications with the currently recommended first-line ARV regimens. The study provides a clue for what we can expect and highlights what we have to be aware of, and the health system need to be prepared for with regards to HIV and aging. So let me highlight 4 NCDs that is important to be aware of for people living with HIV. The first one, cardiovascular disease. People living with HIV are at increased risk of cardiovascular disease compared to HIV negative people in the same age range. Cardiovascular disease accounts for an increasing proportion of mortality among people living with HIV, particularly for those who are living with unsuppressed viral load or lower CD4 cell counts. The mechanisms driving and contributing to this excess risk include HIV-specific factors like chronic immune activation and inflammation, which is also seen in elderly people. ART-related changes in fat composition and behaviors such as smoking and alcohol consumption. Knowing this information, people living with HIV need to be screened for cardiovascular disease. Type 2 diabetes. People living with HIV are more likely to have type 2 diabetes. As with cardiovascular diseases, HIV-specific factors include chronic immune activation, inflammation, and some ARVs can speed up the development of type 2 diabetes. Comorbidities such as liver disease from alcohol use or viral hepatitis and drug interactions may also increase the toxicity of ARV drugs. Next, please. Cervical cancer is another one. In many parts of the world, cervical cancer is the leading cause of cancer-related deaths among women. Women living with HIV have 6 times higher risk of developing cervical cancer and are more likely to develop it at a younger age than women without HIV. Cervical cancer is one of the most preventable types of cancer through vaccination against HPV. However, only 10% of girls in low and middle income countries have access to HPV vaccination, compared to 90% in high income countries. Besides prevention, women living with HIV require regular screening to ensure timely detection and successful treatment to prevent them from developing cervical cancer in the first place. Mental health. Unfortunately, mental health issues are common among many people living with HIV. Studies have found that people living with HIV are more likely to suffer from depression, anxiety, substance use disorders, and other significant emotional, and medically unexplained somatic complaints, such as fatigue and chronic pain. The struggle is higher for people living with HIV who are aging, due to prolonged impact of living with HIV and stigma and discrimination, as well as feeling survivor guilt from losing loved ones to AIDS when HIV was a terminal illness. Mental health is often neglected, but it is really paramount to well-being as well as good health, including self-care and treatment adherence. We need to ensure that people living with HIV who need mental health support can receive services as they become older. There's also healthy lifestyle. I think NCDs can be exacerbated by risk behavior like smoking and alcohol misuse, which is common, but they can also be exacerbated by lack of exercise and insufficient. And in fact, the entire population, whether we have HIV or not, really need to practice healthy behavior. Integration of services can be a key. Integration of services is highlighted in the Global AIDS Strategy under Strategic Priority 1, where it states that adolescents, youth, adults living with HIV, particularly key populations and other priority populations, know their status and are immediately offered and retained in quality, integrated HIV treatment and care that optimize health and well-being. The 2025 targets, these new targets that the world have adopted, also echo this adoption of people-centered, context-specific, integrated approaches where people are linked to services they need, including non-communicable diseases and mental health for overall health and well-being. This is a major progress forward because this new strategy really focuses on the issue of integration and comprehensive services. Next slide, please. There are benefits and challenges that still remain for advocating for increased integration of services. Of course, the benefit include that people are screened and referred to services for non-communicable diseases. Early screening and treatment also lead to healthier and longer lives for people living with HIV. People living with HIV will need to undertake less number of health visits, may also improve follow-up and adherence to treatment. Integration of services may improve testing and treatment initiation as HIV becomes more streamlined into other disciplines. It may also reduce stigma and discrimination of HIV itself as testing for HIV becomes more routine. It's also an opportunity to move away from disease-centered approach to people-centered approach. Benefit for the health system level is the use of existing health and community systems, sharing community and health outreach workers, civil society organizations, and support groups that are already working on HIV, which will benefit the communities at large. The remaining challenges are funds are still disease specific. There's limited multi-sector coordination. There's also inadequate practice and guidance strategies for integration, and task shifting and job sharing may not always work because we always run the risk of overburden already stretched community health workers. And there is challenges also in monitoring and evaluation, and the fact that we still have limited evidence of the benefits and effectiveness and cost efficiencies of integration. Slide, please. I'd like to also talk a little bit about aging in general in Indonesia. The modeling data from the Ministry of Health projects that by 2045, almost 20% of the entire Indonesia population will be 60 years and older, compared with only 8% in 2015. And non-communicable disease trends among the elderly and pre-elderly also show that type 2 diabetes and prevalence of other NCDs is increasing among the older population. 32% of elderly people in Indonesia do not have health insurance and would have to rely on family and community for support. Around 70% of elderly live with family, 20% are living as a couple, and almost 10% are living alone. Challenges for an aging society include the exclusion of elderly in policies, inadequate financing for the elderly, and limited integration of elderly healthcare. The Ministry of Health in Indonesia have a life cycle approach to healthcare with SMART, Sehat, Mandiri, Active, Productive. They have also developed an elderly health working group with handbooks and guidance. But there are still, and they also have activities, for example, health programs tailored for elderly, such as integrated health service posts and the offering of home and long-term care. However, challenges remain as the number of elderly people increase and there's inadequate healthcare facilities that are elderly friendly. And there's limited number of healthcare workers that are well-trained in elderly services, and still limited research on the topic of elderly health and the needs of elderly people. Slide, please. Some recommendations for consideration to ensure healthy lives of people living with HIV as they age. The first recommendation must be the integration of services. As aging people living with HIV need to be linked to appropriate care, this can be done by integration of services, awareness of issues related to older age, including mental health, and active screening of aging people for communicable diseases as non-communicable diseases, as was mentioned earlier. And this is true also for the whole aging population, but people living with HIV are already facing challenges accessing services and are therefore at even higher risk of being left further behind if they develop comorbidities related to older age. There seems to be also no or very few safety nets. And even in our region where family, sense of community and respect for the elderly are highly valued, if a person living with HIV does not have someone to support them, they have to fend for themselves, which is more difficult at an older age when healthcare systems are less accessible and most programming is catered to people of working age. The second recommendation is to maintain a healthy lifestyle. This is really key, and especially true for people living with HIV who are aging, to minimize the risk factors for developing non-communicable diseases. The third recommendation is to have more studies on HIV and aging. There are very few studies in preparation for this statement. There's really very, very few studies that I could rely on. And so therefore, there is very limited evidence to base progressive programming on. Yesterday, we heard from Ibu Merinda, who presented the preliminary findings from a study on aging with HIV in 10 Indonesian cities that the Jaringan Indonesia Positive and UNFPA are currently conducting. We heard that as people living with HIV age, they need support from care providers, particularly on nutrition, mental health and well-being, and social support. Unfortunately, we also heard that stigma and discrimination just doesn't go away and are still being experienced. UNAIDS look forward to the final results of the study that can be used as evidence for advocating for programs for older people living with HIV. More research and studies are needed as we strongly suggest the National HIV Network Research Network to prioritize the topic of HIV and aging. The fourth recommendation is resource investments. Human, technical, financial resource investments must be made to better understand the situation, needs, and lived experience from people living with HIV who are aging. We must also prepare the health system to be able to respond to the needs of older people living with HIV. Expecting to reach 55,000 people living with HIV who are older in Indonesia by 2030, we need to ensure that people living with HIV receive health screening and integrated services they need to allow them to live good and receive good quality of life. In closing, as we look towards ending AIDS by 2030, we will succeed to support more people living with HIV to live long and healthy lives. With this success, we will see more people living with HIV get older, and they will have specific needs that come with old age. It is vital for Indonesia to look ahead and ensure that the health and community systems will be able to provide a full life cycle support to all people living with HIV in Indonesia and leave no one behind. I am grateful for the organizers of this symposium to shine a light on this important topic and provide a wake-up call to all policymakers to do the right thing, redouble their commitment, and ensure policies and resources are in place for a strong, resilient HIV response that allows for all people living with HIV to live dignified, high quality, productive lives. Thank you.
Thank you so much, Ibu Tina, for the wonderful speech. It is well noted that there are diseases, preventable ones, and also it is also well noted that these 4 preventable diseases, although it is expected that we will have it, but those are preventable, and early screening is the key, and also this early screening could increase the quality of life of people living with HIV as we get older in the coming years. So thank you so much, Ibu Tina, once again. And I would like to welcome our moderator of the day. The first panel session of today, which is the 3rd panel session of the whole symposium, will be Dr. Nicholas Hardy. This panel session will be discussing about HIV and cognition, and Dr. Nicholas Hardy will be our moderator for the 3 great speakers that are already available this morning. And I would like to ask Dr. Hardy to take over the floor. Thank you so much, Dr. Hardy.
Okay, thank you, Caroline, and thank you for the organizer of UAIS 2021 organizer for inviting me to this event. Okay, good morning, dear participants. It's been good pleasure for me to be here today and discussing the 3rd session panel for the symposium, which is an interesting topic that always related with aging in every population, that is cognition. As we know, cognition or cognitive functions serve as an important role in our daily life. It helps us to receive, selecting, storing, or recalling information. Unfortunately, during aging, our cognition tends to decline, so elder people are more likely to experience cognitive impairment. At the same time, people living with HIV currently gains privilege. As HIV treatment advancement, they could have a better or a longer life expectancy due to the promising benefit of the ARV treatment. However, we could see some neurocognitive problems related to the HIV still occurring, such as hand or HIV-related dementia. As we also learned from yesterday's session that the inflammation process is always occurring during the times of the systemic aging might happen, and people living with HIV might have a faster aging process than the general population. So today we will discuss more about the HIV and cognition. Could it be that the process of the inflammation or the aging process put the people with living of HIV at risk for having any cognitive impairments? And we will discuss more regarding this phenomenon with our 3 great speakers who already joined us in this session. Before I start the session, let me briefly reminder about our session process. Each speaker has 20 minutes to deliver the presentation, and please allow me to remind you when the last 5 minutes before your time is up. Every participant may type down any questions for the speakers in a Q&A feature. You may find it at the Zoom application. Please remember to reveal your name, and also please mention the speaker's name if you're expecting any specific speaker to answer your questions. The discussion session will be held after all speakers delivered their presentation. And also, the committee provides the interpretation feature. Please feel free to use it. We hope the language adjustment will be able to help you to comprehend the material better. So let's move to our first topic. It's about the HIV neuroinfection and Alzheimer's disease will be presented by Dr. Yuda Turana, a neurologist. Currently, he is attending the School of Medicine and Health Science at Atma Jaya Catholic University of Indonesia. So let me briefly introduce him, who is also my teacher. We could see that he has extensive work as the educator. He also a researcher at the Dementia Project. We could see involved in the WHO Dementia Research Project, Straight Dementia Project, and also at the Ministry of Health Republic of Indonesia. And also he is joined some organization like Indonesian Society of Gerontology and Neurogeriatric Study Groups at Indonesian Society of Neurology. So I believe Dr. Yuda may give us more insights about the HIV neuroinfection and Alzheimer's disease. So is Dr. Yuda here with us already?
Hi. Good morning, everyone. Very happy to see you all. Maybe committee can share my video. Thank you. Good morning, everyone. Thank you for the committee that already invited me in this very wonderful event. So I will share about the HIV neuroinfection and Alzheimer disease. Sorry, show presenter. Okay. This is the objective, the epidemiology of the global aging. I will share also about the HIV and other risk factor of cognitive impairment and dementia, and also about the HIV as the neurotropic virus, and HAN, HIV associated with neurocognitive disorder, and Alzheimer's disease, whether the same common pathway mechanisms. So, as the world age its inhabitants get older and Asia is aging rapidly, some developed countries in Asia, such as Japan and Korea, it is predicted that the elderly will reach 30% of the population in 2030. And in that year, almost all countries will become aging countries with an elderly population exceeding 10%. And getting older, I think doesn't matter, but old age itself is a risk factor for various diseases, including cognitive impairment. With the advances in health technology and drug discovery, like in this context of presentation, like the discoveries of antiretroviral treatment, it will reduce the mortality rate, but will increase the likelihood of developing a degenerative disease, like degenerative disease in the brain, with the consequence of cognitive decline, dementia, with the negative impact on the declining of quality of life in older people. So 38 million people had HIV/AIDS in 2020. A couple of decades ago, the chance of surviving more than 10 years with the HIV were slim. But today, thanks to the antiretroviral therapy, people with HIV/AIDS can expect to lifelong lives, and the treatment has saved millions of lives. The chart here show the annual number of deaths from the HIV/AIDS and the number of deaths affected as a result of ERT. And ERT not only save lives, but but also gives a chance for people living with HIV/AIDS to live long lives. Indonesia didn't have the national data of dementia, but maybe only the data from the prevalence in the province level. The data from our publication in Yogyakarta shown us that around 20% of all the people have probable dementia. I think this data is not much different with the other data in Jatinangor, West Java is around 29%. If we take a look also on the data from Riset Kesehatan Dasar, Basic Health Survey from the Ministry of Health in 2013, like healthy aging without disease is only 13%. And the data from 2018 from Riskerdas also, Basic Health Survey from Ministry of Health, all the data of vascular risk factors tend to increase like hypertension, diabetes, obesity, smoking, and physical inactivity. And all this data, epidemiology in Indonesia, shown us that the dementia become our challenge, especially in Indonesia, in the future. So this is the classic figure of several major risk factors of dementia, Alzheimer, and also protective factors to slowing the decline of cognitive function. Learn from the pandemic COVID with the infection of SARS-CoV that also as neurotropic viral can influence directly to the brain, but also indirectly induce the cognitive impairment. And also can interact with the other factors that to accelerate cognitive decline. Even COVID can inhibit the protective factors like social, mental, and physical activity indirectly. Less is known about the cognitive consequence of aging with the HIV compared to normal aging. One study found that in HIV positive individuals, the age over 50 years increased the risk of developing of cognitive disorder threefold compared to the HIV negative control. Like in this article, as people with the HIV AIDS, they may be at risk of other neurologic disorder associated with aging, such as vascular dementia, Alzheimer's disease, and also the Alzheimer's disease. Thus, the complexities around the neurological health for people with HIV may be increasing. So, HIV is a retrovirus that depletes CD4 cells and strongly impairs the immune response, thus opening up the way for the opportunistic infection. However, the immune system is not the only target. HIV is sometimes classified as a neurotropic virus, even though it cannot directly infect neurons due to their lack of expression of its main receptor, CD4. Nonetheless, the virus can access the brain very early on during a primary infection, like within the first 2 weeks, where it can locally replicate. And the virus then leads to neurotoxicity that is associated with the motor, sensory, and cognitive impairment in around 50% of HIV patients. These neuronal impairment are collectively named HAN, HIV-associated neurocognitive disorder. Depending on the severity of the symptoms, these conditions are classified into three groups: asymptomatic neurocognitive impairment, mild neurocognitive disorder, and HIV-associated dementia. Clinically, patient can display a range of symptoms from cognitive deficit like memory, attention, language, behavior, motor, and sensory impairment, mood changes to dementia, even thought asymptomatic patient present higher risk for developing cognitive impairment compared to control, and have been proposed to mirror early phase of Alzheimer dementia. As on the previous slide, with the introduction of successful combination antiretroviral therapy, the incidence of HAN has decreased, but however, its prevalence increased, mainly due to the increased life expectancy of the patient, cardiovascular risk factor, exposure hazards, and ongoing nervous system inflammation despite CRT. Patient diagnosed with the HAN with mild or severe cognitive impairment have a lower quality of life and shorter lifespan. Moreover, neuronal disorder are becoming more frequent in the aging HIV population. So, proposed mechanism of the HIV-associated neurocognitive disorder through the infected monocyte can cross the blood-brain barrier by the Trojan horse mechanism. In the central nervous system, neuroinflammation triggered directly by viral replication or by HIV viral proteins like GP120 or like activator of transcription TAT, and also the viral protein VPR, and also negative regulatory factor, it's called NEF, that can exert the neurotoxic effects. And the impacts neuron integrity and lead to Alzheimer disease like characteristic such as abnormal tau phosphorylation, oxidative stress, and excitotoxicity. And also the virus can induce neuroinflammation by several mechanisms, direct infection of the associate, blood-brain barrier impairment and peripheral macrophage infection, or massive gliosis and cytokine release. Finally, the HIV patient present with the high glucocorticoid cortisol level. Characteristics of this is characterized by hypothalamic pituitary adrenal or Sp.S axis deregulation. Glucocorticoid and their receptor are highly involved in the etiology of Alzheimer's disease, and by this numerous pathway, is IV-induced synaptic deficit and neurodegeneration does lead to cognitive and behavioral deficit. And moreover, some study aim to see whether the neurocognitive deficit are still found in the population where the viral load is well controlled, while some cohorts show that the cognitive function are generally not affected in individuals with not detectable viremia. Others suggest that there is still a high prevalence of HAN in HIV aviremic patient. This could be explained by several non-inclusive mechanisms such as poor GRT regime penetration of the blood-brain barrier, toxicity of the antiretroviral, prolonged lifespan of the infected individuals, local low noise viral application, and also chronic neuroinflammation. Continuous inflammation injuries could pave the way for some neurodegenerative disorder. How about HAN and Alzheimer's disease? Is there the same common pathway mechanism? So we already know that Alzheimer's disease is devastating neurodegenerative disorder and the most common cause of neurodegenerative dementia in the elderly. It is characterized by progressive impairment of cognitive function associated with synaptic and neuronal loss, as well as senile plaques and neurofibrillary tangles in the brain. And it's become a chronic disease with the advent of the CRT. An important proportion of the HIV patient population is now over 50 years of age and also facing age-related disorder. In addition, accelerated aging, including immunosenescence, is a constitutive part of the natural history of the HIV infection. Regarding the Alzheimer's disease, question have risen about potential links with HIV GNS infection from observation and studies demonstrating that modulation of common pathway or mechanism such as the amyloid and tau pathways. So is HIV patient presenting hand show that the GSF features very similar to early and late stage of Alzheimer's disease. For instance, like biomarkers such as amyloid beta 42 are found to be dysregulated in the GSF of hand patient. When comparing GSF from age-matched control, hand and late stage of AD patient, a similar trend for decreased amyloid beta levels was found also in HIV. Notably, that the HIV patient without neurological symptoms had levels of amyloid beta in the same range as non-dementia controls. So, emerging evidence suggests that the brain exposure to HIV particles and HIV proteins can directly or indirectly modulate the amyloid and tau pathways. And in the animal study, neurodegeneration is observed and associated with the apoptosis, gliosis, oxidative stress, amyloid beta synthesis, and increases in tau phosphorylation. So, like the GAG polyprotein was shown to increase the amyloid beta production and associated with the neurotoxicity. And in HIV transgenic rats, level of phosphorylated tau were markedly elevated in the hippocampus and associated with the increase in CDK5 activity, the other main enzyme that involved in the tau phosphorylation. So in HIV patient treated with the CRT, the adrenal gland is frequently affected, resulting in higher serum cortisol levels, both in the early stage and severely affected patient. In addition, an excess of circulating glucocorticoid can also dysregulate numerous brain function. As glucocorticoid act in the synergy with the glutamate, deregulation of the Sp.A axis activity or modification of glucocorticoid function can be toxic, especially in the hippocampus by inducing excitotoxicity, neuronal damage, neuroinflammation, oxidative stress, and cognitive decline. And in Alzheimer's disease, cognitive deficit and psychological symptoms are associated also with an early deregulation of Sp.A axis and elevated levels of glucocorticoid in plasma and CSF. Along this line, glucocorticoid and stress appear to induce abnormal tau hyperphosphorylation and accumulation. And this regulation of Sp.A axis can increase the amyloid beta pathology and subsequent tau accumulation and hyperphosphorylation. So this figure is a proposed mechanism by which glucocorticoid and their receptors modulate and potentiate the development of hand and potentially Alzheimer's disease. Glucocorticoid overexposure in combination with the viral protein or not is able to induce the the increase of the amyloid beta production, tau phosphorylation, excitotoxicity, oxidative stress, neuroinflammation, and apoptosis. It should be also mentioned that amyloid beta itself can trigger tau phosphorylation, excitotoxicity, oxidative stress, neuroinflammation, and cell death. All this process lead to the neurodegeneration and synaptic deficit, and potentially responsible for the cognitive decline observed in hand patient, and all of which could be progressively favor to the development of the Alzheimer dementia. So this is the conclusion. The acute and chronic neuroinflammation can induce and accelerate a degenerative process in the brain, and inflammation in particular in the brain is a clear hallmark of the HIV infection and can also be found in the virally suppressed individuals. And HIV neuroinfection shares many pathway and characteristic of the familial and sporadic forms of Alzheimer's disease. The HIV population is aging and starting to face age-related disorder like dementia in HIV patient. Could be due to the either HIV, but also to Alzheimer's disease, or a combination of both. The similarities between HAN and AD, one of the challenges facing neurologists will be to discriminate between advanced cognitive impairment caused by HIV and Alzheimer's disease. And I think this is the last slide, the dysregulation of Sp.S axis that can associate with HIV infection and could favor an environment where oxidative stress, neuroinflammation, excitotoxicity, blood-brain barrier disruption, and amyloid beta load are exacerbated, and combined with the other factors, paved the way for the establishment of brain diseases such as Alzheimer's disease. And HIV infection may represent a risk factor for Alzheimer's disease and other related neuronal disorder. And early recognition and treatment have a positive impact on quality of life and health outcomes for those living with HIV. Okay, thank you very much for your attention.
Okay, thank you, Dr. Yuda, for the absolutely great video to introduce us about the process of neuroinfection of the HIV and the impact and the process into the Alzheimer's disease. From this session, we could learn that there are several factors that make the cognitive decline happens, such as the uncommunicable disease, non-communicable disease, or any aging process that make the cognitive decline more easily happens. And also the neuroinflammatory process, we could not be easily disputed. So we will move to the next session, to the next topic. I mean, it's also related about the neuroinflammation itself and the neuroinfection. As we know, when the HIV patient reach into the low level of the immune system, they are prone to have the opportunistic infection. So we will learn more about the effect of cytomegalovirus in HIV cognitive function from Dr. Riwanti Estiasari. She's also a neurologist consultant, as I know she is consultant in neuroinfection at Cipto Mangunkusomo Hospital, Jakarta, and at the Faculty of Medicine, University of Indonesia. Her last degree is a doctoral program at the Biomedical Science. She also has extensive work and research about HIV, neuroinflammation, and the cognitive function. So we will learn more about the effect of the cytomegalovirus. So please, Dr. Riwanti, are you already joined with us?
Yes, Dr. Nicholas, I am here.
Okay, so Dr. Riwanti, please take your screen and the next 20 minutes is yours, please.
Okay, may I share my screen? It's disabled. Okay. Is my voice clear enough?
Yes, clear.
Okay, thank you. Yeah, thank you, Dr. Nicholas, for introducing me. First of all, I'm Riwanti Estiasari. As Dr. Nicholas already introduced, I'm from University of Indonesia, Cipto Mangunkusomo Hospital. Thank you for the committee for inviting me to participate in this very important meeting, the University Center of Excellence Research Center International Symposium 2021. My topic is the HIV cognitive function and the role of the CMV. This talk will be based on our work, the collaboration between University of Indonesia and Curtin University. So, I think this already mentioned by Dr. Yuda, how the antiretroviral successfully decreased the AIDS-defining illness, including the HIV dementia. We know that the prevalence of the HIV dementia decreased significantly after the introducing of antiretroviral. And of course, it will affect the quality of life, but with the increase of life expectancy, we will see more cases with the milder form of cognitive impairment. Yeah, it's also already mentioned by Dr. Yuda how the CNS is a good place for the HIV. The CNS is a sanctuary for the HIV. HIV will infiltrate the brain during the primary HIV infection. And the proof is that we found the RNA in the CSF of the HIV patient, even though the patient not showing any neurological symptoms. HIV will bind to host cell like CD4 and chemokine receptor CXCR4 and CCR5, which is expressed highly in the T lymphocyte and monocyte. And this cell will carry the HIV genome and bring it to the CNS through the Trojan horse-like mechanism.
Sorry, Dr. Riwanti, excuse me.
Yes.
Can you please share the slide, or is the slide moving at your slide and our slide? Because we still see at the first slide here.
Oh, sorry. Actually, in my it's already moving. I think I got a problem. Okay. Okay, so this is the second slide.
Okay.
Yeah.
Yes, the background, we could see it now.
Okay, so I think I cannot use the slideshow because it's not moving in the slideshow. I'm very sorry.
Okay, it's fine.
Okay, so I will use this format.
Okay, please.
Okay, so okay, thank you. Yeah, for it's inconvenience. So yeah, I already mentioned about this. How the antiretroviral is successfully decreased the age-defining illness, including the HIV dementia. And this is how the CNS come into the CNS, and the HIV is infiltrate to the CNS during the primary HIV infection. And we found it in the CSF of HIV patient, even though the patient not showing any neurological symptoms. So the HIV will be in the lymphocyte and monocyte and will enter the CNS through the Trojan horse-like mechanism. The viral entry of HIV across the blood-brain barrier due to the transcellular uptake of the virus by certain chemokine receptor on the microvascular endothelial cell of the blood-brain barrier. So the viral entry target the breakdown of the blood-brain barrier structure by altering the tight junction protein that tightly bind the microvascular endothelial cells. Sorry. Okay, so this study showing how the blood-brain barrier is disrupted in HIV patient. So this study showing how the Q albumin, the ratio between the albumin in the CSF and the serum in HIV patient is elevated significantly comparing to the healthy control. And the Q albumin is also related to the neurofilament light chains, which is a subunit comprises in the cytoskeletal protein neurofilament. That is essential for axonal support. So the NFL is a CSF biomarker of the axonal damage. It's also correlated with the NAA creatine level, but the key albumin ratio is not correlated with the neuropsychological performance. A study in the inflammatory cerebral metabolite also shown that the metabolites are elevated in acute HIV infection. And the HIV infected cell reside within the brain can maintain undergoing viral replication. So after they enter the CNS, they will replicate inside the CNS, and it will associate it with the neuropathology. Okay, so this is the charter study. I think this is quite inspiring study. It's quite big study involving 1,500 HIV patients with the broad inclusion criteria. Even though it's all 2003, 2007, but the result is very good. So they are using the Frascati criteria. That's also already mentioned by Dr. Yuda. The hand, it's come from the Frascati criteria, and 52% of their subject showing a neuropsychologically impaired. And the neurologically impairment rate is different if they look based on the comorbidity group. In the incidental comorbidity group, it's 40%, in contributing 59%, and in confounded comorbidity group is 80%. So the cognitive impairment in HIV not only affected by the HIV itself, but it's also affected by many factors, such as neuroinflammation, neurodegeneration of aging, and then the antiretroviral itself, toxicities, polypharmacy, mental health, stigma, and many things that can also interfere the cognitive impairment in HIV. This is our study. So we also want to capture how is our HIV patient cognitive function. So we do the cohort study in Cipto Mangunkusomo Hospital. We include HIV positive patient with CD4 less than 200, with Karnofsky performance scale 70 to 100, living in Jakarta, and agree to participate. We exclude patient with a history of injury, stroke, recurrent seizures, severe depression, neurological deficit, so everything that can interfere the cognitive function or interfere, they are doing the cognitive evaluation. We match the subject with healthy control by age and education level, and we do the follow-up for 3, 6, and 12 months. So the assessment is not only cognitive, but also in CMV burden, ophthalmology, and cardiology assessment. But for my talk today, I will only talk about our cognitive assessment. So this is the result. This is the test that we use in our cohort. We use the forward digit span and backward digit span for the attention, animal naming test for fluency, and ray auditory verbal learning test for memory, trial making for executive function, and group backboard for the motor speed. We can see here that the healthy control have a higher score comparing with the HIV subject, and the difference is significant, except in the executive function. And then we follow our subject for 3, 6, and 12 months after they got the antiretroviral. We can see here the successful of antiretroviral. So after the antiretroviral, the CD4 increased significantly and the viral load decreased significantly. How about the cognitive function? We calculate the cognitive function from all domain into a Z-score. So we comparing with the score from the healthy subject and their standard deviation. And we found that the Z-score, the cognitive function of our subject, is significantly improved from before antiretroviral to 3 months and 6 months. But after 6 months, 6 months to 12 months, the function is stabilized. If we take a look for each domain, we found that only memory function that not improve after the antiretroviral. The other is improved. In Australia, they also found improvement after the ART, but a little bit different in time. They found that the improvement is happen after the 12 months. So we also try to figure out what is the factor that contributed in HIV cognitive status in our patient. So what we found is that the baseline Z-score correlated inversely with age in HIV patient and education. I think these two factors is not surprising if it is associated with the education. The other finding is that the Z-score is significantly higher in people with MSN than those with heterosexual or IVDU. Our patient also have a clinically contributing factor like lung TB and Hep C. Almost half of our subjects have lung TB, 50%. But when we analyze the correlation with the cognitive status, we find no correlation between the cognitive status with the lung TB and also with the Hep C, viral load, and CD4. So we know that HIV have a hallmark. It's an immune activation. So it will lead other pathogen to activate it. So the other pathogen like CMV, EBV will reactivate in HIV patient, and their reactivation will be worsen the immune activation in HIV patient. So we check the CMV burden in our cohort. We found that the burden is very high. So the titer is very high. And when we follow up the titer of the antibody or the CMV antibody, we found that it kept increasing in the IE antibody. And CMV antibody lysis is kept increasing in 6 months and a little bit decreased after the 12 months. CMV is a beta herpes virus. We know that it can infect CNS in neonate or in adult. And it establishes latency within the myeloid progenitor cell of human and can establish persistent infection in the CNS, and the affinity is in the limbic system. So we hypothesize that CMV also will affect the cognitive function of HIV, mostly with the reactivation of the CMV. Other study also show that the CMV seropositive individual had lower cognitive ability at age 70. So in older, it's also affected. And in non-elderly, it's also showing association between the higher level of CMV antibody with the lower level of cognitive function. Oops, sorry. So how about in our cohort? First, we do the bivariate analysis. Yeah, we found that the CMV lysis antibody is correlated with the memory function, but not with the total Z-score. So only with the memory function. And the subject with low score of Z memory before the antiretroviral tends to have higher CMV lysis antibody level. And CMV antibody also correlate with fluency and motor speed. But after we put all of this in our multivariate analysis, trying to see whether the improvement of the cognitive is also affected by the CMV, we found that the CMV is not come out from our analysis. The improvement of Z-score were influenced by age, education, and CD4 T cell counts. So this is the summary of our study. So we know that the HIV will affect the CNS before the antiretroviral, and after the antiretroviral, we can see many successful from the CD4 increment, the decrease of the viral load, the increase of the Z-score of the cognitive function. However, we found that the CMV burden is very high and it keeps increasing. Maybe it can be due to the immune activation that's still ongoing on HIV patients. And in our study, we found that age, education, and also the CD4 are associated with the improvement of the cognitive function. So for the conclusion, the cognitive function in HIV recovered after the antiretroviral and stabilized after 6 months in our study. Age, education level, and CD4 influence the cognitive impairment. CMV antibody level inversely correlated with memory function in bivariate analysis, but not in multivariate. Memory function did not improve after antiretroviral. This is the only one domain that not improved. And we think that we need to explore more marker of CMV footprint that might affect the cognitive function. So this is our team, the Jack and the team. I'm very happy can work with all of them, especially with our teacher, Professor Samsurizal, and also Professor Patricia Price, who will give a lecture after this. Thank you so much.
Okay, thank you for your great presentation, Dr. Riwanti. So from Dr. Riwanti's session, we could learn that immune activation from the HIV first infection could raise some problem, and it also could become burdensome for some people, although the promising hope from the antiretroviral treatment already could help people to increase their cognitive function. So we will learn more about the process or the poor outcomes from the CMV infected patient in the HIV population from Professor Patricia Price. Her topic is about what is the best way to assess the contribution of CMV to poor outcomes for HIV patient responding to ART. We could learn that Professor Price is a principal research fellow at the Curtin University, also as adjunct professor at University of Indonesia, and also the research fellow at the University of the Witwatersrand. And she also have extensive work about the biomolecular from the immunology system and also with the HIV patient. So I would like to invite Professor Price to join us.
And it's very nice to be invited. Thank you very much for that invitation. I'm just pressing to share screen at the moment. And I'm not good at this. I'm sorry, I've just pressed the wrong button. Where am I? My apologies for this.
No problem, please take your time.
Okay, where am I? Here. Can you see my talk now?
Yes.
You can, and you can hear me.
Yes.
Wonderful. My apologies for that.
No
I pressed the wrong button suddenly and everything disappeared. Okay, yes, thank you for inviting me to talk at this conference. It is a very impressive undertaking, and I'm very honored to follow the two previous speakers. My own situation is that I'm based at Curtin University in Western Australia. But I have a very long-standing collaboration with the University of Indonesia. Indeed, it's been continuing since 2006. In 2012, I met Dr. Riwanti, and she was the driving force for establishing the Jack Can Do project. So the data I'm going to present in this talk is mostly from Jack Can Do, but there's also some lessons that we have learned from the work that we have done here in West Australia using studying renal transplant recipients. Did that advance to slide 2? Riwanti, is that slide 2?
Yes, it's
Hello?
already moved to, yes.
Yes, good. Okay, I'm going to take a step back because my focus is going to be cytomegalovirus, CMV. I'm going to just tell you a little bit about it. It's a herpes virus with a very big DNA genome. It has about 200 genes, which is a lot more than COVID and HIV. It replicates in quite small numbers of fibroblasts, monocytes, and endothelial cells and causes a lot of inflammation. This picture here is a heart section from a patient with myocarditis to do with CMV. And there is one CMV infected cell there in the middle, and you can see the large amounts of inflammation. CMV becomes latent and persists for life. Recent meta-analyses have shown that 83% of the population of the whole world are CMV seropositivity. So that's most of us. The key fact is that it replicates in the salivary gland. So it's shed in saliva. So for anyone living in the community who has ever shared a spoon or been in a public transport which is crowded, there is no possibility that you've led a life without exposure to CMV. What does CMV do to you? Well, we've developed a term called the CMV footprint, and that is the footprint, the impression that CMV has made to your health and to your immune system. We're hoping to use this to identify individuals who will benefit from prophylactic treatment to reduce their burden of CMV. But the first key stage to understanding the footprint of CMV is to understand the CMV burden. How much CMV do people have? Now, as I mentioned before, it mostly replicates in fixed tissues, and mostly the samples that you get from people are either blood or saliva. So how do we assess the CMV burden in HIV patients? This is data that Riwanti showed you a few minutes ago from the Jack-Can-Do cohort. It measures levels of CMV antibody detected with a lysate of infected cells and detected specifically with the IE protein, which is the first protein expressed when CMV is replicating. So it marks CMV waking up from latency. And you can see from this that the levels of CMV antibody rise as the patients begin therapy. Now, we don't really expect them to have more CMV when they're on therapy, because in fact, they've got a better immune system. If anything, you'd expect them to have less. What we think is happening here is that they become able to make the antibody. Now, if we say then that at 3 and 6 months, the antibody levels are perhaps representing how much CMV they have, by corollary, if you think back, the levels of antibody before they started therapy would have been underestimating the burden of CMV. Perhaps looking for CMV DNA itself is a better way to assess the burden of CMV. This can be done, is routinely done with transplant patients. But of course, we have to remember that CMV replicates in the blood, not in tissues. So our chances of missing it are quite considerable. We found that the best way to find CMV DNA was to look at blood neutrophils. And there, what we're looking at is cells which have picked up the rubbish from infected cells that have died. And what we find in the Jack-Can-Do study is that half the patients have CMV DNA in their blood leukocytes that you can detect with a really simple qPCR. Now, if you apply this really simple test to Australians, you find nothing at all. So to get half the patients who are DNA positive, CMV DNA positive when they begin ART is an enormous number of patients. Even the ones who were CMV DNA positive and DNA negative had the same levels pretty much the same levels of CMV antibodies. So in other words, it's not that the ones who were CMV DNA negative had no CMV, it's just that it was below the detection on our assay. Indeed, the assay is separating people who have absolutely enormous amounts from people who have quite a lot. So, what are the consequences of having CMV that are evident from the literature? In fact, using as metrics either CMV seropositivity per se, a history of CMV disease, or high levels of CMV antibodies, you can find associations with almost every disease of aging. Cancer, periodontal disease, dementia, all-cause mortality, that's sort of a disease of aging, and cardiovascular disease. And in this, out there in the literature, cardiovascular disease is assessed in very many ways. What we've used is the CIMT, which is the thickness of the walls of the carotid artery, and FMD, which represents vascular endothelial function because it's the elasticity of the blood veins in the blood vessels in the arm. So a healthy person has a low CMT and a high FMD. This is data from our Australian study. We were running multivariable analyses to predict FMD in healthy adults, I've called them controls here, and in renal transplant recipients. And what we found was that levels of CMV reactive antibody were a major component of the prediction of FMD in renal transplant recipients. Not in healthy controls, but in renal transplant recipients. These are people who had more CMV antibody than healthy controls. The main determinant of CIMT in the Australian study was age. The associations with CMV lysate were not particularly strong. You could sort of find them in the healthy adults. But the big determinant was age. So, does CMV also affect cardiovascular disease in HIV patients? And this is Jack-Can-Do data generated by Dr. Biri and Dr. Ika at Cipto Hospital. And the data we have here are two measures of cardiac function, the ejection fraction and the EA ratio, and the CIMT. The CIMT rises a little on ART, but the differences here are not great. Push the wrong button. We tried to look at what predicted CIMT. Nothing in age, gender, or smoking. Nothing with pulmonary TB. And plasma CRP, this is a general inflammatory marker. The levels stay high in these patients, but they don't associate with cardiovascular disease. CIMT increased at V2 and did not correlate with CD4 counts or HIV RNA. The only association we got with CMV DNA was with the EA ratio. A low EA ratio indicates poor ventricular filling between contractions and marks a risk of heart failure. And in fact, the low ratios were found in CMV DNA positive patients, especially before ART. But what we believe is that this reflects CMV myocarditis, that this is actually a local effect in the heart, and it disappears on ART. In validating CMV antibodies as a metric of the CMV footprint, we got pretty comfortable with them by 6 to 12 months on ART. This little plot shows a relationship between the antibody levels at V6 and the antibody levels at V12, and they correlate beautifully. In other words, if we pick a person with a high burden of CMV at either of those time points, based on their antibody levels, we'll pick the same person. And in fact, after 5 years on ART, we have associations between CMV antibody levels and CIMT and FMD. As I mentioned before, high CIMT is bad, low is good, and high is FMD, it's the other way around. So we see nice associations after 5 years on ART with these two measures of cardiovascular disease. Some delightful work that was done by my good friend, Dr. Endar, who's a dentist, showed that periodontitis and CMV antibodies were the big predictors of CIMT at 5 years, which is a very interesting study. It's been published in JADES. So we have two means of measuring, we've so far presented two means of measuring the burden of CMV, the antibodies and the DNA. Also, we know quite a lot about the impact of CMV on the immune system. It induces the expansion of novel and interesting populations of gamma delta T cells and NK cells. And we address the possibility that these novel populations are actually a better metric of CMV than the antibody response itself. I'm going to talk here about the gamma delta T cells. They comprise 5% of cells in blood. You can read there the sort of functions that they have. They come in two sorts, V delta 2 pos and V delta 2 neg. I'm going to say it briefly like that. Otherwise it's rather a long name. This is about our renal transplant recipients again. The red is the renal transplant recipients, the blue is the healthy adults, the filled circles are people who are CMV seropositive. And you can see the highest level of delta 2 negative gamma delta T cells, V delta 2 negs, is in renal transplant recipients who have both CMV antibodies and CMV DNA detectable by an Abbott assay, which is screamingly sensitive. So it's not necessarily very much DNA, it's a really sensitive assay. So V delta 2 neg cells are a marker of the presence of CMV. So what happens in Jack-Can-Do? Well, all Jack-Can-Do patients have more CMV, have more V delta 2 neg cells and less V delta 2 pos cells. This is without separating by their level of CMV. So just the HIV patients have a switch from delta 2 pos are lost, delta 2 neg are gained. Now, what's the correlation? And in fact, the strongest correlation, unlike the Australian study where the delta 2 negs were the most interesting, here we found the delta 2 pos were the interesting one. And remember that we've shown that the delta 2 pos are lost in the HIV patients. So it's how many of them are remaining that is interesting. Going the wrong way now. There we are. Delta 2 pos cells correlate inversely with CMV DNA in the patients who have CMV DNA. Well, this is at the beginning of ART, and with CMV antibody levels. and that is true at the start of ART, which is in orange, and after 6 months in red. And when we correlated this with memory Z scores, remember Riwanti said that the memory Z score is the one that doesn't recover on ART. We get a very clear correlation between the V delta 2 positives at before ART and at V6 with our memory scores. We then divided up the cohort based on whether they had CMV DNA. Now, what we found then was that the correlation was even stronger in the people who were CMV DNA negative. Now, you might expect it to be the other way around, but remember, the ones who are CMV DNA negative are not really CMV negative. Absolutely. They still have a lot of CMV antibody. They just have a bit less. So they're not showing up on the DNA assay. So V delta 2 pos gamma delta T cells associate with memory Z scores in individuals with a lower burden of CMV. And what we think is happening is that in the ones with the really high burden, how much CMV you have just doesn't make any difference. You're off the top of the scale. The question comes is whether these V delta 2 pos cells are just a marker of the burden of CMV, or whether they are they have a role in the pathology. And we've done this little plot. This was done when we, as a graphical abstract for the paper we've submitted. It's going to take a lot more thinking to determine whether this population of gamma delta cells actually has a role in the pathology in the brain. And finally, before I finish, because all of this is far too simple, I'm going to tell you why CMV is much harder than you just thought. CMV has 200 open reading frames. That means active genes. Most of them are not needed for the CMV to grow. What they are copies or homologs of cellular genes which have been picked up during the evolution of CMV from the CMV that grows in mice through the CMV that grows in monkeys. And as we evolved from mice, we brought our CMV with us. And along through those millions of years of evolution, we have picked up, our CMV has picked up genes from our immune system. And the fact that you can find similar sort of pickups in mouse CMV as you can in human CMV rather suggests that these are useful from the perspective of the CMV. They help the CMV to persist. And the one I'm going to just mention here is US28, fascinating molecule. It's a chemokine receptor, a human chemokine receptor, which is now encoded by CMV. It's part of the virus. And we've compared virus that was generated from our Jack Can-Do patients and from our renal transplant patients in Australia and some babies and various other people. And what we've found is all those sites which you can see there marked in yellow are actually different. They differ. There's polymorphisms at those positions. Differences between the viruses that we can isolate in all those different populations. And these differences affect the ability of this molecule, US28, to act as a chemokine receptor. It's shown here as a receptor for fractalkine, and also its ability to act as a receptor for HIV GP120. It is possible that you actually get the same cell infected with CMV and HIV because CMV offers a new door into the cell. And that may be relevant to carrying CMV into the brain. So having thoroughly confused everybody, I'm just going to thank all my co-workers. The Jack Can Do family depicted here, Ibnu, Biri, Lukman, Riwanti, and Ika, myself, and Prof. Samsu, who has been so important in getting this project running, and the two ladies in my lab at Curtin, Sylvia, who makes everything work and gives us all the lab methods, and Shelley, who's done the US 28 work. So thank you to all my co-workers, and thank you to the organizing committee for having me here today. That's it.
Okay, thank you, Professor Price. It's also nice for us to have you here today with us. Thank you for sharing and reminding us about the CMV nature and how the footprints from the from the biomolecular aspect could help us to detect and best predict the outcome of the contribution for the HIV patients. So next we will start our discussion session. I would like to remind every participant who wants to ask, you may type down any questions for the speakers in the Q&A feature. Please skip to reveal your name, remind it, and also please mention the speaker's name if you're expecting any specific speaker to answer your questions. So I would like to invite all our three speakers today to open the camera and maybe we could start our discussions today. I already see there are 4 questions here. Sorry. The first question comes from an anonymous attendee. He said, "Thank you for your insightful presentation. I would like to ask your opinion about screening cognitive impairment. How important is it to do routine cognitive screening for patients with HIV at Puskesmas? Maybe we should say the primary services. Can you recommend any tool that doctor at the primary services could use to do the screening?" Maybe Dr. Yuda can help to answer.
Thank you, Dr. Nicholas, and thank you for the question. Maybe I will answer the question, and maybe Dr. Riwanti also. That we already know that the tools that are popular in Indonesia that always teach in our medical school, like MMSA, mental state examination, and the other one is the MOCA, Montreal, Canada assessment. But since I think in a lot of study in the HIV cognitive impairment related, usually involve also the domain of the executive function. So based on that, I think the suggestion maybe is better use the MOCA-INA. That MOCA that already validated in Indonesia is called MOCA-INA, and everyone can access that screening. And the second one, I think, thank you for the question and reminding us that it's HIV itself in the context of dementia, as dementia is an umbrella, is HIV itself is like one of the risk factor, especially the subjective or the objective cognitive impairment in young onset. So I think if you have the HIV patient and the patient have the subjective complaint about the cognitive, I think the doctor should have the data, the baseline data about the cognitive impairment in patient, because it's very important in the cognitive impairment. We have the baseline. So someday we can follow up the patient, and we know objectively if the patient is have the cognitive decline, because we can mention about the cognitive decline if we have both of data, like the cohort studies, because the tools is very influenced by the education. So if we have the two data at the baseline and in the follow-up, I think it's better for the doctor. So my answer, maybe Dr. Riwanti can add something about the cognitive screening.
Okay, please, Dr. Riwanti.
Yeah, thank you, Dr. Nicholas and Dr. Yuda. Yeah, I'm agree with Dr. Yuda. MOCA-INA is already available in many languages, and it also already validated in Indonesia. And there are many studies also showing that the MOCA-INA has a good sensitivity for HIV cognitive impairment screening. So I think, yes, we can use it in Puskesmas, and many of our doctor in Puskesmas also already trained with the MOCA-INA, how to use the MOCA-INA. Yeah, even though until now there is still no kind of an established recommendation what kind of tools that we should use for the HIV cognitive impairment, and the treatment is still yeah, there's still no recommendation treatment if we found the cognitive impairment, but we can review the whole treatment of the HIV patient if we found the cognitive impairment during the treatment. It can be caused by many factors. So first of all, of course, we have to check the HIV response itself during the antiretroviral, and we also have to see another factor that can be contributed in the patient. I think that is from me, Dr. Nicholas.
Okay, thank you for the great answer from Dr. Yuda and Dr. Riwanti that remind us there are also already a simple tool that we could use and already trained at the primary facility that is MOCA-INA that have a good sensitivity, although we don't have a good guideline currently, but we may use it to have established the basic or the baseline cognitive measurement, so we could follow up and we could help the patient when we detect any more further cognitive decline. We could help them to have a better cognitive function. So let's move to the second questions. It's for Dr. Riwanti. Thank you for sharing your interesting study. Would it be possible that the cognitive will be declined again after 6 months despite the ART, especially in the older patient, please?
Yes, of course. In our study, we also found the association between age and the cognitive function. So the age will be one factor that will contribute with the cognitive function. So the older the patient, the cognitive function will be declined. And we know that the aging process in HIV patient is more faster than in the healthy patient. So we can imagine that the degenerative process in the brain also will be more faster comparing with the healthy person. Yeah.
Okay, thank you, Dr. Riwanti. So we could learn that the aging process and the degenerative process is faster and it's related with the age despite of the patient already got the antiretroviral treatment. So we need to be aware. And this is related to the third questions. It's about what can we do to prevent any decline of the cognitive function when we get into older age with HIV? So I think it's related. So any speakers who wants? Okay, Dr. Yuda, please.
Yeah. Thank you, Nicholas. Maybe I can answer in Bahasa. It's okay because the question in Bahasa.
I think it's okay. We have that interpreter.
Okay. So it's okay. I will answer in English also. It's okay. So I think it's very interesting question, but I always answer that the cognitive decline in old age is not start in the old age, but it start in the in the middle age, even in the early of life. So I think this is we must think that the prevention is not start in the old age. A lot of study that Dr. Riwanti repetitive mentioned that the cognitive decline is caused by not just only by HIV, but it's the complex multi-factors. Is HIV just only one factors, but we must include the other factors. Sometimes the other factors, maybe the major one, not the HIV one, like the HIV with the depression. Maybe not just the HIV itself that make the cognitive decline, but its depression caused by the HIV may be the major one. So I think also with the other major factors like the vascular risk factor like hypertension, diabetes, smoking, the social isolation that I think impact also in elderly with the HIV. The elderly itself have the social isolation, but I can imagine the elderly with the stigma, negative stigma of HIV maybe is more severe social isolation. So to prevent cognitive decline, especially the HIV in the older age, I think we must to take a look a lot of this factor. And in every person, I think we must have the specific approach, what kind of the measure that make him or her to become the cognitive decline. So that's my answer. So I think we must have the holistic, comprehensive approach to see a lot of factors in every person with the symptom of cognitive decline.
Okay, Dr. Yuda, thank you. So we need to assess the whole system from an individual person. So maybe the collaborative interdiscipline approach might help the patient, and we can help them to identify more any risk to prevent any cognitive decline as they are aging process. So Dr. Riwanti, do you want to add anything, or Professor Price?
I think it's already complete by Dr. Yuda.
Okay, great. Thank you. So we might move to the next questions from Handayani P. Handayani said, good afternoon. She would like to ask the cognitive function impact that needs to be looked into for the people living with HIV, and it is related with Dr. Yuda's statement about depression. The HIV patient is using the ART and antidepressant for years as in they are aging. Dr. Yuda, do you want to give any comment?
Yeah, thank you. I read the question. Okay, so I think the answer is almost the same because I think even in the era of the pandemic, in the midst of the pandemic, I think we face not just only the physical risk factor, but I think the big problem is not just SARS-CoV infection, but the mental health problems. I think this pandemic also, because in my practice every day, that a lot of the patient come not just because of the direct effect of the viral infection, but about the mental problem like the cognitive impairment, the depression, and a lot of study also that social isolation, the same like the 15 cigarettes a day, the risk of the mortality. So in the context of this topic, I think this is very interesting topic that we held by the committee about to combine the keywords of aging, keywords of the HIV. This is like the double burden, and if we put in the one person other than that with the HIV, I think a lot of story, a lot of the things that in one person, like I have the patient other than that with the stroke, and he has the HIV also. That's the complex thing. A lot of mental health problems, a lot of the the depression, a lot of things. That's I think my question. I'm not a lot of experience about the antidepressant, but I just want to say this is like the it's very burden, it's very big issue. It's the complex issue if we put the other adults with the HIV and the context of aging, and not just two of them, but with the other comorbidity. Is hypertension, diabetes, and hypertension in 70% of aging, all the other adult, the diabetes also, and a lot of things. Then we put together, I think is the complex problems.
Okay, great. Thank you, Dr. Yuda. So when people living with HIV have any more comorbidity other than the HIV itself, we need to put more concern because it will be burdensome for the health worker or maybe for the patients itself, we should say. So they need maintain to maintain the treatment and maintain to keep regulating their system, their physical, their mental health, so they could be better from days to days. As we know, mental health also might compromise the person's immune system itself. So Dr. Riwanti, do you want to add any comment about this question?
Yeah, so one thing that the patient should remember, especially if they still have low CD4, so there's still high risk of opportunistic infection, which also can have a symptom like cognitive impairment. So it should be they have to pay attention for that. So if the cognitive impairment is worsened progressively, especially for them who still have a CD4 below 200, then yeah, I think it's just about the time to seek for the medication help. I think that's it.
Okay, great. Thank you, Dr. Riwanti. So Dr. Riwanti remind us to keep regularly check the CD4 levels to remind us about the potential of the opportunistic infection, because it may masking with the cognitive impairment, and maybe the patient will need more extensive attention to make his conditions improve. Okay, so thank you, Handayani, for your questions. Next is questions from Aditya Putra. This is for Professor Price. It was such an enlightening presentation. And first of all, I would like to congratulate Professor Price and the team for the great work and contribution. There are some questions that came up to my mind in which I am curious whether it is clear that even the mildest form of CMV will significantly lead to poor outcomes of HIV's course of the disease. The concept of CMV will open a new door in the cell itself is an interesting insight. Can you elaborate more about it? Many thanks, Professor.
Okay. With regards to the amount of CMV, we have yet to find a HIV patient in Indonesia or in our Australian cohort who was CMV seronegative. So every HIV patient has CMV. So how much CMV has a bad outcome, I can't say. I would be fairly confident to say that having more is a bad thing. And indeed, all of the Indonesian patients have higher CMV antibody levels than all of the Australian HIV patients who we've ever measured. So the burden of CMV in your population is certainly high. CMV, when it infects cells, will express US28, and that US28 will serve as the chemokine receptor component of the cell-based receptor, the same as any other chemokine receptor would be. We all know that HIV to get in needs CD4 and a chemokine receptor, and US28 will serve. It's an interesting observation because going back to the 1990s, there were a number of observations of HIV and CMV infecting the same cell. And it was usually a monocyte because that's on the list of can infect cells for both viruses. And at the time, I always thought that's so unlikely. Such a small percentage of cells are infected with each virus. How often would you get both viruses in the same cell? But in fact, you do. And there's even talk of exchange of genetic information between those two viruses. Perhaps it is a driver of the evolution of the CMV. That would be speculation, but it is possible. We're not yet at the stage where we would say that it's time to screen HIV patients to reduce their CMV burden. But I think it is a case of watch this space, and it may be that within 5 years that is recommended in some circumstances. That's it.
Okay, great. Thank you, Professor Price. So we could know that every patient have already maybe infected by CMV, although they are seronegative results test. So we might take attention for the potential for in the future, and maybe
none of them are seronegative. Every HIV patient has CMV reactive antibody. And every Indonesian one has a lot.
Oh, okay.
As a way of measuring this, in our laboratory, we would dilute a sample 1 in 100,000 to test for CMV antibodies. In Australia, we would dilute the sample 1 in 100. It's a big difference in the amount of antibodies in the Indonesian samples.
Okay, so I think we need to put awareness for the cytomegalovirus itself. Okay, thank you for the insight. So we do hope that in the future we could have a better guideline or established guide to help us to identify it first, so we could prevent any more serious impact, especially at the cognitive we are talking today.
Cognitive or cardiovascular, yes.
Yes. Okay. Thank you, Professor Price, for your insight. Okay, let's move to the next questions. It's also from an anonymous attendee, and I think this is really interesting one. He asked about the impact of the consumption of the antiretroviral which is expired. Is there any impact? And there is some people in the health facility that give statement that it's okay to not consume the antiretroviral treatment for some times in the next months. And is there any research to support this statement? And because maybe the person asked that to not panic because of the lack of the ARV in the public. Maybe it's about the logistic or the supplies in the field. Or Dr. Yuda or Dr. Riwanti, do you have any comments about this? I think it's an interesting question about it.
Maybe Dr. Riwanti can answer the question. Maybe Dr. Riwanti can help to answer the question.
Yeah, about the expired drug. Yes, sometimes we face the things like this. Not a good story, but I think I don't have any competency to answer this question. Yeah, I'm not sure how to answer it. Yeah, maybe we have to. I think the anonymous attendee who asked this question always checking the date of the drug that he received. That's very good. That's something that we should do every time we want to take our medication. Yeah, and yeah, the only thing that we can do at that time is only asking in our health facility why this already expired and can we change to another medication. But I'm very sorry, I cannot answer how long from the date, how much that we can still tolerate with the expired date. But I think we should not tolerate it. It is the safest one. Yeah.
Okay, Dr. Riwanti. So I also see that this question is interesting because we need to pay attention for the safety from the drug itself. Is it safe for the patient? And when the patient could not have access to the drug, it is safe to, let's say, absent from the drugs for some quiet times? Or maybe Professor Price, do you have any insight about this?
There has been some big international studies comparing intermittent treatment with continuous treatment. And the continuous treatment obviously is better in terms of CD4 recovery and that sort of thing, but it's also better in terms of the side effects of the drugs. So the general message to be out there is that one should get continuous treatment where possible. I have no idea on the subject of dates. That one's a tough one.
Okay, thank you. I should say, sorry, maybe we could not answer this topic in this session. Maybe you could ask also at the other topic that maybe involve the more experts in this field about the safety of the drugs, of maybe the supply system in the fields to help the people living with HIV better. Okay, let us move to the next questions. Maybe this is for Professor Price. I conducted CMV tests at the hospital before the pandemic. My anti-CMV IgG was reactive with 135.5 AU per milliliter, and my anti-CMV AGM was non-reactive with 0.09 index. Should I do a retest, and what should people living with HIV do to prevent the CMV?
What can I say? It is quite common that you have a IgG positive and IgM negative. In fact, most people are IgM negative. It is likely that most people are infected with CMV when they are little children, that they have carried this all of their lives. So yes, HIV patients have a higher rate of positivity than the general population, but still most HIV patients, like 80 or 90%, actually got this in kindergarten. And then, of course, because of immunodeficiency, it may be less well controlled. At this stage, there is no action that one would take to minimize it. We're still at the research stage. That's really all I can say.
Okay, so it is already common for people already bring the immune system for the IgG or the CMV itself. So it might quite safe, you mean, for this lab result?
The result is absolutely not surprising.
Okay.
It would be very common amongst people living with HIV. And at this stage, there is no recommendation to do anything about it. Okay. However, that doesn't prove that it's not important. What is needed is more research.
Okay, is there any specific further retesting needed for a patient with the titer of the immune system for CMV?
There is no, I believe, and Riwanti may correct me on this, I believe there is nothing scheduled in that respect. Okay. Just for a person who is asymptomatic. Now, I mean, there are some acute conditions associated with CMV in HIV patients. Retinitis is the best known, but it can also cause meningitis and pneumonitis, and we group these as end organ disease. They're most common in untreated patients. Okay. So the acute conditions are what you see, and indeed I showed you a little evidence there of the myocarditis. But that's not to say, basically that's easier to define. The long-term effects are very hard to study. And it would be great if we could continue studying. We have all the systems in place, but unfortunately, I think we've reached the end of our work.
Okay, great. So currently there are no really established guidelines, and it is quite generally accepted for these kinds of condition. And to prevent the infection itself, I think we need to keep our immune system at a well-maintained level, just like as you said before.
Take the pills, yes.
Okay, thank you, Dr. Riwanti. Do you want to add anything?
Yeah, I think Professor Patricia Price already mentioned. So for those who are not controlled well with the antiretroviral, the CMV can give more problem like retinitis, meningitis, encephalitis, pneumonitis, and it is in CMV encephalitis will manifest it with a very bad, very severe cognitive impairment. Sometimes it can make the patient very like a bedridden, then there will be so many comorbidity will come out, and yeah, it will be very bad for the patient.
Okay, thank you, Dr. Riwanti. So continuing and sustainable therapy for the antiretroviral, that is compulsory for the people living with HIV. Okay, so maybe this is our last questions for today's session's discussion. It's come from Aditya Putra. He says, thank you to Dr. Yuda and Dr. Riwanti for the remarkable works. He would like to ask both of you about the major confounding factors related to the cognitive decline in CMV seropositive people that can be missed by the clinically assessed by physician, moreover in the primary healthcare setting, especially in lower middle income countries. Maybe some specific tips to look into.
Yeah.
Okay, Dr. Yuda.
Yeah. Thank you for the question. But I think this is the general condition, not just only for the CMV infection, but almost in the context of the cognitive screening, especially in the elderly. The first in the low middle income country, we have I think it's more than 50% of elderly have low education level, and we know the assessment of the cognitive screening is very influenced by the education. So sometimes even in the doctor itself thinks, or maybe this is because of the low education level, or the instrument is not well validated in that area. This is the first one. And the second one, something like the false perception, like forgetfulness. People think just as a part of normal aging, something like that. So even the instrument already validated, the doctor examined well, but if the scoring is low, sometimes it's said normal on the community perception, because it's already old. Is very normal to have like the forgetfulness like that. So maybe that's the two major confounding when we perform the cognitive assessment in the setting of the primary healthcare in the low middle income countries. Yeah.
Okay, great. Thank you, Dr. Yuda. So you mentioned the education at the population in lower middle income countries might interfere with the result itself. Okay, Dr. Riwanti, do you want to add something more?
Yeah, I think that's what also we found in our study, that age and education is affected the cognitive function in our patient. The other factor, another study showing that the CD4, there's another study also show that the viral load. So back again to the antiretroviral, the treatment, the continuation of treatment, keeping the CD4 higher, it's very important to keep the cognitive function good in HIV patient.
Okay, thank you, Doctor. Okay, thank you, Dr. Riwanti. So that's also important to keep our health condition at the perfect condition when we are examining the cognitive function. So thank you for the questions, Aditya. The committee just informed me we still have a few minutes, so I might want to deliver the last questions for Professor Price. It's coming from Risla. She wants to ask about how we, as the people living with HIV, could learn about whether we are infected or exposed to CMV. Is that any requirement for us to check ourselves routinely? And is there any kind of way to prevent prevent for the exposure? I'm not sure, but maybe you could have any comment about this.
It is likely that people living with HIV were exposed to CMV when they went to kindergarten, nursery school, primary school, very early in their lives. CMV is transmitted in saliva, and little children put things in their mouths and share them. That is the first time for infection of most people. So as an HIV patient, this is not something you should worry about. You're not catching it now. CMV becomes latent, so you keep it for the whole life long. It's not like coronavirus, which you get and cure, or influenza, you get it and you cure. Your CMV you keep for your whole life long. It hides in some of your cells, and sometimes it wakes up and your immune system controls it. But if your immune system is very weak, then that control won't be that good. So the message for somebody who has HIV is to take your antiretrovirals every day and keep your immune system as good as it can be. And that will control the waking up of your CMV. That's it.
Okay, thank you, Professor Price. So the main issue is the CMV already easily infected already, or we exposed to the CMV in the early of our life, maybe from the transmission of the saliva for the sharing things between each kids. There's also already a risk. So whether we will have problems from the CMV itself, it's also depend on our immune system. So we need to maintain our immune system in a great level or a good level so that CMV would not infect it and would not cause any damage to ourselves. So thank you for your insights. So maybe people here, they are questioning about the potential of the effect of the CMV, may learn that maintaining immune system itself is important because the HIV will have risk for we to reduce the immune system. So taking the ART at the same time at the routine time, it will improve the immune system and will most likely reduce the impacts in the long term. So thank you for the speakers and for the participants who asked. Okay, before we close today's sessions, I would like to ask every speaker to give any closing remarks or take-home notes for us to bring. Okay, Dr. Yuda, please.
Okay. So I think my closing remarks is in order to manage holistic about the HIV neurocognitive disorder, I think we must include the HIV as the one of the risk factor, like the same way we consider to put the hypertension, diabetes, depression as a risk factor of cognitive decline in the old age. That's the first one. And the second one, I think the early recognition and I think early treatment and control about the immune system that Prof. Patricia Price said and Dr. Riwanti said, I think it's very important in this topic to prevent the cognitive decline in the older age with HIV. That's my closing statement. Thank you.
Okay, thank you, Dr. Yuda. Next, I would like to ask Dr. Riwanti.
Okay, thank you, Dr. Nicholas. So Indonesia now have successfully in antiretroviral treatment, but besides that, we're still facing the new problem with the aging and also the cognitive impairment, even though it's in the milder form. So I think it is important to keep in mind for all physicians who are treating the HIV patient, there will be a burden of a cognitive problem in our HIV patient. So doing a screening in the beginning of the antiretroviral treatment, if it is possible, then it will be it will give a benefit for the patient, so we can evaluate the cognitive function after the treatment or during the treatment. That's from me, Dr. Nicholas.
Okay, thank you, Dr. Riwanti. Okay, Professor Price, you may take your time.
The message that I'd like to give people is how we have been able to how we are striving to, how we are working towards having innovative science and improvements in the medicine. I'm personally a scientist, and I've been greatly honored to work with physicians such as Dr. Riwanti, and it makes a partnership, a team, where the scientists can contribute the underlying theory and the ways of making measurements, such as our gamma delta cells and our CMV DNA measurements. And the clinicians can link this with what actually happens to the patients. It's been brilliant to me to be in such a partnership. And I think it is something that should be sought in other university settings, to have a partnership of scientists and clinicians in that way.
Okay, thank you, Professor Price. So from this session, we could learn that it's compulsory for us to keep maintaining the therapy for the HIV itself. So we could have a great amount level of the immune system. So we could prevent much other problems that already burden for the HIV patient and for the health workers and every stakeholder that is involved in managing HIV infected cases. So thank you. So we really hope that in the future, more research or more groundbreaking guidelines maybe could help the people with HIV could have a better days in the future. So I really thank you for our great speakers for joining us, and thank you also for the participants with the really many questions and really engaging discussions today. So it's great pleasure to discuss with you all. Okay, thank you. So now I would like to give the time back to our host, Caroline, please.
Thank you so much, Dr. Nicholas Hadi, Dr. Yuda Turana, Dr. Riwanti Estiasari, and also Patricia for sharing a very wonderful presentation today, this morning, Jakarta time. Yesterday we had, and thank you so much, Dr. Nicholas, for your guiding and moderating for the first panel session of today. It's very enriching talk for the day. Yesterday we had a very general perspective on aging and HIV and also social aspects of aging, and it is exciting to see a deeper topic today on HIV and cognition. We will have another topic this afternoon. Please stay and bear with us. And very important key points from this session is that it takes interdisciplinary approach to manage HIV and cognition problem. And since HIV can also cross the blood-brain barrier, it is important to start and also to be adherent to ARV as much as possible. We will now have a 1 hour break from 12 to 1 p.m. Jakarta time, but during the break, we will have 5 poster presentations. Feel free to join us during your lunch, and also each poster presentation will last for 10 minutes. I promise you it's a very interesting one. And again, if you have any queries for the poster presenters, or you have any burning questions for the previous presenters, you may type it in the Q&A box and we will help to address it to the presenters. Now I would like to introduce our poster presenters of the day. The first one with the abstract title of Frequencies of STI and Mucocutaneous Manifestation in Elderly Patients, Elderly HIV Patients in Yogyakarta. The author, there are 4 authors. The first one is Aditi Retno Pujiati. Second one is Alessandro Alfieri. Third one is Devi Artami Susutiati. And then the next one is Nurwestu Rusetianti, and the last one is Agnia Purnama Putri. And the second abstract presenting in poster with the title of Policy Analysis of HIV Regulations on the Province of South Sulawesi, a critical analysis on a gender methodology, by Nur Aini Gigi Simon La Hussein. And then the third one is Relationship between Knowledge and Sociodemographic Characteristic with Stigmatizing Behavior towards People living with HIV, by Via Dolorosa Halilintar. The fourth one is Knowledge of HIV/AIDS among young adults through media leaflet, I Am Proud to Know, by Lusa Rohmawati. The last one is the influence of Sasak tribes' indigenous knowledge in creating a safe community for people living with HIV/AIDS by Lalu Haris Noval Mahroja. So please enjoy. We will start at exactly 12, but please stay with us. You can have a short break and also lunch, and enjoy, and see you at the next session at 1 p.m. Jakarta time. Thank you so much, everyone, and have a great break.
Morning, everyone. Thank you for giving me the opportunity to present my poster with title